everybody, welcome back to the Overrun Podcast. My name is Ed Bowder.
And I'm Dan Schwester.
And once again, we have Dr. Andrew Fisher with us. Dr. Fisher, how we doing?
Good. How you gentlemen doing?
Very good. We're happy to have you back on the show. Today, everybody, we're going to talk about whole blood. This is a big topic that's been in EMS for a while. Last month, we talked to Dr. Antevi. We talked about plasma and how freeze-dried plasma is probably going to come out to the field. Dr. Fisher has been at the forefront, one of the bleeding edge researchers on whole blood in the field. We talked to him previously about combat medic work. And today, we're going to talk about sepsis and whole blood because now that we have a solution for trauma, we're going to give whole blood, and now we have this whole other problem. So, Dr. Fisher, I'm going to bring up this study that came out. This is Gallagher et al. From February of this year. And essentially what these findings showed was about 4%. There's a 4% possibility of sepsis per unit of whole blood given in the field. So, Dr. Fisher, welcome to the show. Welcome back to the show, I should say. First thing we want to talk about, obviously, we know that whole blood is I hate to say a new thing, but now it's kind of the new hot button topic. But talk to us about whole blood, talked about these complications, and then we're going to kind of unpack this and spend some time on this topic.
Yeah, sure. Yeah, it's been out now for, when we started about 2018 when we really started seeing whole blood and EMS, and it's grown substantially, especially I think after COVID, we saw a big increase in number of programs being able to carry it. Trauma centers have steadily and started increasing using whole blood during their resuscitations. So I think it kind of goes with, as soon as the hospital systems kind of get on board, I think that kind of does some trickle down to the EMS system, which is great. I think it's probably, I do believe it's the best resuscitation product that we can give, period, whether you're in EMS or in a hospital. In that very acute resuscitation setting, we can, once you get out of that and we have hemorrhage control and then you do things like TAG or whatever measurement you're using to determine a more, a guided resuscitation based upon, what they're lacking, whether it's, they need PXA or, if they need, whole blood or if they need plasma or platelets, there's a broad spectrum of things that we can give a more guided resuscitation. But in the acute setting, whole blood or the most balanced resuscitation you can give with blood products is best.
And I think that's definitely right. What was interesting about this is, because again, there's always kind of the next logical step, right? Like, all right, so we have this hemorrhagic trauma. Now we know that if you lose blood, the best thing to do is to give whole blood. We're going to talk about, freeze-dried plasma and all that in a bit. But what I think is interesting is, because everything, it's easy to look at things from a 10,000 foot view, right? And it's like, all right, trauma equals whole blood. Boom. That's easy. What I think is interesting about this paper and about the research that you guys have been doing is, all right, so we know that whole blood is the problem. What's the downstream effect, right? So if we have an elderly trauma patient, which, fall victims and whatever else are a fairly large percentage of patients, the findings that you guys found with a 4% increase odds in sepsis with each unit of whole blood, I think is very interesting because it speaks to the kind of the long-term progression for the patient in the hospital. So after seeing these findings, what's the most interesting part about this to you? What's the next step after seeing this data?
Yeah, I think you have to also look a little bit closer. Like if you look at table 1, specifically, I think the reader and the people digesting this should take into account, we see some of the significant differences between, these two cohorts. And, specifically if we look at, the ISS, right? ISS is 29 in the sepsis group and 19 in the no sepsis group. And yeah, I mean, even if you look at the no severe sepsis, the ISS is still, severely injured people, but that's pretty big difference between the ISS. So I think we kind of have to think about, what are the differences between these two populations, and could that potentially contribute to what we're seeing? More severely injured are more likely to have, I think, more significant issues, longer ICU stays. In the ICU, there's risk of, all sorts of adverse events, DVTs, PEs, pneumonias, sepsis, all that. And, you kind of have to consider that when reading this. And I think if you look at things like the thorax, if we look at the serious injury, thorax is higher in the sepsis group, along with extremities. All those sort of those areas where you can be injured, I think also may contribute to potentially setting you up for sepsis. especially large open wounds, or chest injuries, to where you can't necessarily take large volumes of breath, then you set yourself up for pneumonias, or they may be on vents longer. So those things I kind of think about. However, I do think, as we've been putting out, there's all sorts of different adverse events that may be associated with this. We already know there's data out there that suggests that, trauma patients require blood transfusions do tend to have, higher incidence of, things like sepsis and adverse events, DVTs.
And just to be clear, the data isn't suggesting that the whole blood is causing the sepsis, right? So there's always these complications in trauma where no one ever experiences a traumatic injury in a sterile environment, right? It's all universally, your trauma patient is going to be like on a pile of mud, and that mud just has been infused with E. coli and all that other kind of stuff, right? No one, no one ever falls on like a clean, tile floor. It's always the most complicated place they can fall. It stands to reason that they'll have, whatever pathology term you want to throw out, fomites or infectious agents, whatever. If I'm out in the field and I have no open wounds, one thing leads to another, and now I have several, it makes sense that all those portals to infection would, introduce a pathogen. So it's not to suggest that the whole blood itself actually causes the sepsis, but we have these patients now where, all right, you had this hemorrhagic injury, we give you whole blood, now we fix that problem. What this paper is suggesting, or what the data is suggesting, is, all right, now we fixed this. Fixing this has not necessarily caused, but has led into this next problem that we're going to have to consider, right? It's not so much that we're causing these issues, just to be aware of, and this gets into pre-hospital antibiotics and all those other things as well. So it's not saying, all right, whole blood causes sepsis. This particular population experiences higher rate of sepsis.
Yeah, there is, based upon our regression analysis, there is an association with that. There's an odds of this happening. Could that be because maybe the whole blood itself causes a different immune response within the body that may, cause patients to be a little bit more susceptible to sepsis? And that's, when I try to think about it, outside of being more severely injured and all this, probably, require more blood products and different treatment modalities. Could there also be some sort of, biological issue, or, something that is setting the body up for becoming more susceptible?
Yeah. Is it a matter of the great unified field theory paper that says sicker people don't do as well?
Yeah.
Imagine that.
I mean, that's the whole thing, right? We've been doing, like, anybody who reads papers, you're like, oh, well, yeah, I thought this was interesting. I like this paper, and I really want everybody in the audience to give it a read, because this is the type of thing where you can learn something. For example, if you look at the abstract of this, you're going to sit there and say, oh, well, that's a risk. Well, we can't do that. And if they have 4 units, it's going to be this. And if it's 10 units, they're going to have this. And I knew somebody who had a massive transfusion one day, and that was 72 units. And if you're getting that from the paper, you're not reading the paper. The paper says this is kind of what happens, but we don't know the correlation. We don't understand that connection just yet. And it might be something nobody even understands, like this I love the idea of this, this transfusion, almost inflammatory reaction, because while your body's like, oh great, I'm going to live, it's also like, hey, what are they doing here? Physiology doesn't shut off, right? So that could be part of it.
Yeah, I think that makes sense, right? Because you're introducing a foreign agent one way or the other.
Right. Yeah, I think it's I think all we're trying to say, and I think people should also kind of understand, whenever they're reading these big database papers that are retrospective, it's so hard to control for so many things, and so it's never the definitive answer that practice should be changed based upon a retrospective paper. We kind of need those multi-center trials and trials that kind of overall, just as we can follow patients along and as perspective, and we can kind of see what happens to patients that way. But I think what these big database papers do is they bring up a lot of questions about, well, if this is happening, why? And helps maybe develop bigger questions to be able to put forth in research.
I think that's one of the biggest hangups with looking at papers and looking at data. And obviously we have our own bias because we do this all the time now. But the idea that one paper can, change practice or change whatever. And we talk about this on the Journal Club. There's interesting papers that, can change little things, right? So, all right, the race score is superior to a Cincinnati score, right? Okay, those kind of little things. I think that one of the things that we tend to do is we tend to see a paper and say, like, all right, this is either, dogma changing or it's not. That type of, binary, I think, reduces our ability to progress in the field. So, and Danny's right. I think people will look at this paper, and this isn't a criticism of the publication, but I think people will look at the paper and say, all right, 4% increase in sepsis with whole blood, no reason to give whole blood because we're just going to make people worse. And while that is the easiest way to look at it, I think, or I guess I worry that people will look at it and say, like, you know what, we're going to reduce our sepsis numbers by not administering whole blood. And it's kind of like, okay, that's going to increase your morbidity and mortality numbers. And of course, we can get into a debate as to whether or not we should be monitoring the numbers and making decisions based on that in the first place. But I think that's kind of the worry when we see these kind of things. So talk to us about the necessary evils of this type of procedure, right? Where you have this patient, they have an exsanguinous injury, we can save them now, and maybe we can deal with the sepsis later. Or, so if I'm a systems director, right, talk to me about these necessary evils and how we can kind of work through them.
I think EMS should be more concerned about anaphylaxis or some sort of reaction to, an immediate setting. I don't think EMS administering whole blood is going to cause these issues down the line. I think that's other issues that are inherent to the patient and inherent to what happens, after EMS drops off the patient. We have the patient for 30 days, and so I don't think EMS should even bat an eye at this paper. I think it's interesting. And I think, even, my other additional co-authors, especially Steve Schauer and Mike April, who I've been, working with for over 10 years now, we try to approach it with as an unbiased view as we can, saying, okay, that's there. What should we take from this? And it's, it's how do we look at this deeper in a more prospective manner? And I believe all three of us would agree, and all the other authors too on here too.
I think it's a really good point, is that we worry too much about EMS's effect on the downstream effects of patients, right? So if, all right, you missed an IV stick, and by missing that IV stick, 25 days later, the patient developed an infection to the site. And it's kind of like, okay, I can't do anything about that.
Right. Yeah. I mean, I don't think a lot of interventions by EMS they do have the potential to have negative downstream effects. But I think what we're seeing as EMS progresses is, taking what we do in the hospital, taking it to EMS because we know that works versus working off old dogma. And I think overall that you just got to worry about treating what you have and treating them to the best of your ability. And I don't think that they need to worry about, unless they intentionally hurt the patient or do something catastrophic that's negligent, then they don't need to worry about it. You do the best you can with what you have, and bring them in, and we'll do what we can.
I think that sounds right. So Dan, one of the things that we've kind of had these problems with, I guess, in the discussion in the industry is that blood is expensive. So let's talk about how we're going to get this money and how we're going to get the money back.
I don't know. And I don't think
great show. Thanks for coming on, everybody. Good talk. Jim did this.
No, it's I mean, I'm kidding, but that's the answer, because we don't know what the impact is. Once this started to break in EMS, you saw a lot of places engaging blood banks, getting their programs up and running. I know it costs $650 to $800 a unit. It's got a 28-day shelf life. Usually that means that they come back in, or it comes back in after a certain amount of time, gets spun into components, but it's an expense. And although the studies seem to indicate that pre-hospital field blood programs don't waste things, they're going to be looking at it. Getting to the point, how are they going to pay for this? I don't know. Are they going to be able to get reimbursements in an environment where it's not going to happen. I don't know. I think it's a really interesting question that has to be asked. I just don't know that anybody has the answer.
I think they've seen some places in Texas. Obviously, down in San Antonio, they published a paper on the cost and everything to set up a program. And I think really the person that is the expert on this is Eric Bank out of ESD 48 down in Harris County, where I'll be lucky to be seeing him here in about a month or so when I get my fellowship. But yeah, I think he was maybe the first one to kind of really figure out how do we get reimbursed for this and how do we at least not lose a whole bunch of money on this. And I'm also in that group of people that I think EMS is a separate entity from the other public health sectors and is also a community requirement, and should be a necessary, absolute thing you have to have. And I think once that happens, that I think would help, city, whatever, municipalities figure out.
That's the other point of the conversation, right? Is that like the word service is in the phrase emergency medical services. So, and this is, and surely we could spend hours having this whole thing, so obviously the most simple way to do it is to accept that EMS is a service and thus we're not a profit generating entity. There it is. Okay. Now we've figured that out. We exist to help the people.
Right.
Failing that, which, and again, what would that we would wake up in the morning and be like, oh, it turns out we figured it out. Right. We're funded, whether we're publicly funded, there's, that one day I'm sure that, we'll try and get to that. In the meantime, medicine is still a profit driver, despite everything being nonprofit. So the question with whole blood is, it's cost per unit. How do you recycle them? When do you get them out? How do you get them out? How do you store it? All these other things. So I think that, or I guess I worry that systems will look at the cost of a unit of blood, whatever it is, whether it's, $650, whatever, and then look at the downstream costs of maintaining that blood. And my worry is that saving these people ultimately becomes a financial decision. And that's something that I have no time for.
Or a corporate decision, Ed, because a lot of places you can advance an idea as far as you want, but it takes one person to shut it down and just it dies on the vine. So these things are going to be hard, and they're going to have these conversations, and we're going to have to lobby. We're going to have to talk to politicians, people who make regulations, to make them understand this stuff. I don't know if it's going to work.
I think even before then, I think the real easy way to go about it is community engagement and working with your trauma centers to help recognize that this patient is alive because of this. And you see these news reports out there highlighting that. And I think if you can get the community invested in this idea that, EMS is going to be able to resuscitate you appropriately, having their buy-in, I think, is also huge. And that's an easy thing to do. There's very little effort in that.
And San Antonio, as you said earlier, is doing a fantastic job with this. They've identified donors in their community. They notify them when their unit gets used. It's pretty amazing. I'd really like to talk to them about it, but, we'll see. Maybe we'll get them on the show, Ed. I don't know. Shoot your shot.
And again, this is one of those interventions where, it's a cost benefit analysis, which is infuriating because, all right, we're going to fix the patient, but it's going to cost us a bunch of money. So, and we talked to Dr. Antevi last month about this, but if I'm in a system and I know, the data is extant, right? We say this all the time on the show. So we know that whole blood is going to fix hemorrhagic trauma, right? That's kind of out. We've known that for a decade. If I'm in a system and I'm looking at, logistics, all right, how do I obtain blood? How do I get it out to people? All that kind of stuff. And I'm running up against a wall, right? It's just too expensive. It's, prohibitively expensive. We can't do it because of this reason or that reason. What are some of the alternatives that are available, right? So I'm looking at, all right, the price point for whole blood, it's just not feasible for my system, but I still want to improve these traumatic outcomes. What are some of the other options that organizations have?
Well, you could always carry like cold plasma, right? So, plasma can be thawed and kept cold, but same as whole blood. And then, hopefully in the near future, you finally see freeze-dried plasma, which, a couple of years sitting on the shelf, surely most units would run into at least one.
Hopefully you get one.
At least what, you don't want. Oh, I don't want people to get hurt, but if we just, it's there for a reason. And so I think the chance of them encountering a patient that would require it in that amount of time is pretty high.
And this is something I think we've talked about previously, and certainly we've talked about it off air, where it feels like we have a lot of products or a lot of supplies that we tend to hold on to in the event that this one, really wild event happens. And like cyano kits come to mind, or, the old, NAC Mark 1 kits that we used to carry after 9/11. And again, it kind of feels like, okay, well, we carry all of these things for the one patient that we had one time in 2008. So why not carry that? Like, if I'm a medic unit out of a trauma center, why don't I have blood on the trauma center unit? So I feel like it's a lot of, well, if we spend X amount of money to get this product, what are the chances that we're actually going to have to implement it and use it in the field, and then get our reimbursement back? I really like the idea, especially the freeze-dried plasma, and this isn't the first time that we've discussed it on this show. I like the idea of there being a product with a shelf life where, if nothing else, I'd rather have the argument of we have too much freeze-dried plasma and we never use it than the argument of we don't have it at all. Yeah. Right. I'd rather it be a problem of abundance than a problem of, of lack of resources. And so with this freeze-dried plasma that's coming out, talk to us a little bit about that. Is that going to be do you think this is going to be the next thing in lieu of whole blood going out, or is there going to be a next, big fancy thing that's going to solve all of our problems in 5 years?
Right. Yeah. I mean, we started carrying the French FDP and SOF, I want to say 2011. In the combat setting, the way they have their, the French do theirs, it's a little challenging to do that rapidly, which is a little bit of a drawback from their product. It works great if you can do it, but it does take a little bit of time and effort. That being said, obviously EMS is different than combat. I'm not carrying this stuff on my back in EMS and expected to do this on the ground. Right. I think in EMS, especially given the way the U.S. products are going to be packaged, I think it's going to be quick and fast. Get it hung, mix it, hang it, run it in. I think it's good, and I think it is going to be a huge game changer. You can look at what IDF has done. You can look at what the French have done with theirs, and they've had great successes over the years. The Germans use it too, but you don't see them published to the extent that the IDF and France.
Well, and that's part of it too, right? It's not necessarily this is new, right? It may be new to us, but and again, there's parallels you can draw all across the world. We've talked about doing field resuscitation, where Danny was in Paris a few weeks ago and he gets to see the SAMU unit. Like that. So there's stuff that other people are doing that you can always work to improve the system.
Here's another question I wanted to ask. And just call me on it. I'm just saying it to be provocative. Do you think that some places are trying to adopt whole blood as kind of a gimmick thing to either draw staffing or to attract?
Come on down to our new hospital system. We have blood.
As kind of a substitute for training or better equipment or different protocols. Could it be a flex? I mean...
Yeah, I think it certainly could be. I would hope that wouldn't be happening. I would hope that the medical directors and, all the great paramedics out there kind of look at it and go, if we look at the data, we do see a trend towards this likely may impact outcomes. So hopefully, but it could be, yeah. If we're going to be pessimistic, I guess. That's what we're going to roll today.
I don't want to be pessimistic. I like the fact, I think this I think this is a big win. And, just to go back, plasma's got a lot more advantages than crystalloid. You don't get oxygen carrying capacity, but you get clotting factors, you get a bigger molecule, stays in the intravascular space, all that anatomy, physiology, pathophysiology you hated in school.
And don't forget about oxygen carrying capacity too.
Mm-hmm.
Yeah.
Well, and I think that's kind of the crux of this whole debate, right? Where it's, and we've talked previously about stop the bleed and how, if I have a bleeding patient, right, what is the actual protocol? What's, how do I stop the bleeding, right? The capital B bleeding. Yeah. And it's been very interesting to kind of watch this process grow over the years where, Danny and I remember not that long ago, we're like, hey, what if we just put something in the wound to stop it? And they're like, under no circumstances can you do that. That's the worst idea.
Ever.
And now, packing the void is like, it's like, of course, that's what you would do. Why would you not do that? So it's been very interesting watching the process. And we've talked about things that EMS should own, right? And as time goes on, as more data is generated, the hemorrhagic trauma is starting to feel more and more like one of those things, right? Like what should EMS own, right? What are our things? MIs, trauma, asthma, whatever. And it's starting to feel like, all right, I have someone who's got a hemorrhagic injury, right? Something happened and now they're bleeding. EMS can come in and stop the bleeding. EMS can come in and pack the wound. EMS can come in and give, TXA. They can give clotting factors. They can give whole blood. They can give plasma. And then bring this nicely packaged patient to the trauma center. And, here's all these things that we can do, right? And you've done a lot of work on these things. And I guess the closing question is, how is progress going so far? And take us out 5 years. What do you see changing as far as hemorrhagic treatment happens over the next few years?
Yeah, I would like to see EMS own compressible hemorrhage control better. I think we took, tourniquets from combat and just said,
yeah, put them on. There you go.
Yeah, you got a lot of people say, well, it won't cause any harm. Well, I mean, it could, right? And so, most of the tourniquets I have seen over the past 5 years are either not indicated or not effective. So I would like to see in 5 years EMS owning compressible hemorrhage control. I think plasma, like I said, FTP is going to be, I think, be a huge thing. Specifically, we were talking offline about, the analysis of combat and pamper, and the conclusion was, hey, if you're greater than 20 minutes, from a hospital or a trauma center, then plasma may improve outcomes. And so I still think within these quick transports within the city, if it's like pick up a patient, I'll be at the hospital in 10 minutes. If you can get hemorrhage controlled, that's great. Or should we expect them to be able to, hang blood and do all that, and will actually make it improve outcomes in that short amount of time? I'm not sure that's we're gonna see that, but I think once you start getting back past that 10-minute, 20, 30-minute mark to getting patients to the hospital, we're just going to probably see better outcomes. I agree, whole blood will never be in every place, but I think FTP is going to make that, so at least we can put something on these ambulances for a couple of years, and hopefully the price will be,
Well, that's it. Once it gets out, right? Once something is put out to market, it gradually becomes cheaper over time. So I think that, and I agree. I think that to an extent, we kind of overcorrected with tourniquets, right? Where we sort of said, like, it's very easy to do. You can't cause any harm. Just go ahead and do it. And just like everything else, like, okay, well, okay, no, slow it down. Bring it back a little bit. No, that's not what we meant. It's like telling a kid, like, go ahead and play on the playground. I don't really care what you're going to do. No, that's dangerous.
Yeah.
Listen, this stuff was taught. This was, early mid 2000s into 2010, maybe, until people started figuring it out. Like this was being taught. I
also think what I like to see is paramedics taking off tourniquets that aren't needed. They're painful. They're terrible. If it's not
we
needed,
do that at our place. So, but I agree.
Yeah, that's good.
That might actually be the more, I guess, the more interesting, dichotomy change here, where taking off tourniquets, again, not that long ago, was something like under no circumstances. Like if you take off, like I remember in EMT school, if you take off a tourniquet, you're going to kill the person.
Never.
And so I think that move is, I think the look of doing things more academically and actually doing things based upon the research, which is the crux of evidence-based medicine, which is what we're trying to do here, is just going to slowly improve over time. The problem that I think all of us have is that we are an impatient lot. That we want the data out now. No. All right, the data is extant. Now let's start making the changes. And the glacial pace of change, I think, can sour a lot of things. But Dr. Andrew Fisher, Stop the Bleed, down from Texas, and doing all the work that he's done. Where can we find you, Dr. Fisher? Where do you want to plug?
Oh man, we shut down the St. Fisher Church of Evidence-Based Medicine page, but John, Nick, and I are still out there. I'm at Instagram at trauma_daddy. Well, we're just on Facebook under Energy Fisher.
Just find it out on the internet.
Yeah.
Dr. Fisher, thank you so much, man. Keep a
Thanks,
lookout
Scott.
for all of Dr. Fisher's data and information, and certainly he's going to be publishing more as time goes on. For the Overrun, Ed Bowder and Dan Schwester, we will talk to you all next time.